So, dear students, today we'll talk about periodontitis, periodont diseases, gingivitis, medical gingivitis, hyperplasia, gingivitis and fibromatosis, and about odontogenic cysts. So, let's start. Periodontitis is an inflammatory process that affects the supporting structures of the teeth, periodontal ligaments, alveolar bone, and cementum. Periodontitis can lead to serious sequelae, including complete destruction of the periodontal ligament, which is responsible for attachment of the teeth to the alveolar bone, leading to losing of and eventual loss of the teeth. Periodontal diseases is associated with a marked shift in the types of proportion of bacteria along the gingiva. Poor oral hygiene with result change in oral flora are believed to be important in the pathogenesis of periodontitis. For the most part, facultative gram-positive microorganisms colonize healthy gingival sites, while plaque with areas of active periodontitis contains anaerobic and microaerophilic gram-negative flora. Although 300 types of bacteria resides in the oral cavity, adult periodontitis is associated primarily with three types of bacteria that you can see on the slide. While it typically present without any associated diseases, periodontal diseases can be a component of systemic diseases, including acquired immunodeficiency syndrome, leukemia, Crohn's disease, diabetes mellitus, Down syndrome, sarcoidosis, and syndromes associated with defects in neutrophils. In addition, periodontal infection can be the origin of important systemic diseases, including infective endocarditis and pulmonary and brain abscesses. Staging. There are two dimensions in the process of assessing the stage of periodontitis in a patient: severity and complexity. Severity. The primary goal is to classify the severity and extent of destroyed and damaged tissue caused by periodontitis. This is done by measuring CAL by clinical probing and bone loss by radiographic examination. This measurement must include the number of teeth whose loss can be attributed to periodontitis. And complexity. Complexity, the secondary goal is to determine the complexity involved in controlling the disease and managing the long-term function and aesthetic of the patient's dentition. Grading a periodontitis patient involves estimating the future risk of periodontitis progression and the likely progressiveness to standard therapeutic principles. This estimate guides the intensity of therapy and secondary prevention after therapy. Grading adds another dimension and allows the rate of progression to be considered using direct and indirect evidence. Direct evidence is based on the available longitudinal observation, for example, in the form of all the diagnostic quality radiographs. Direct evidence is based on the assessment of bone loss at the worst affected tooth in the definition as a function of age, measured as radiographic bone loss in percentage of root led delivery by the age of the subject. The periodontitis grade can be modified by the presence of risk factors. Classification of periodontitis according to Lukomsky. First of all, it's acute periodontitis. Second one is chronic periodontitis, that can be divided into chronic fibrous periodontitis, chronic granulating periodontitis, chronic granulomatous periodontitis or granuloma, chronic periodontitis in the acute stage. Well, first of all, acute periodontitis or periodontitis acuta. Depending on the nature of fluid shared by many arteries in acute cirrhosis and acute purulent. I should say that such a distinction on the basis of the subjective data is not always possible and is not always available. In addition, the transition from serous purulent inflammation is very fast and depends on several conditions, primarily on the condition of the patient. The phase of acute purulent inflammation is characterized by an increase in leukocyte infiltration, and upon microscopic examination, along with the usual signs of acute inflammation, abundant tissue infiltration with neutrophils can be observed. Increased inflammation of leukocytes leads to tissue melting and the formation of the abscess. The adjacent areas of the periodontium, the jawbone as well as gum and soft tissue of the cheek are in state of reactive inflammation, hyperemia or edema. The periosteum is thickened, sometimes exfoliated by pus. A sharp plethora of the bone marrow and focal separation are determined. Complication. In some cases, there is a significant colorectal edema and perimaxillary tissues, of the perimaxillary tissues. With the formation of abscesses, there may be a swelling of the exudate under the thin layer of the mucous membrane of the gum. In the event of breakthrough of pus and the formation of fistula on the gums or skin of the face, tissue tension decreases and the pain becomes less intense. From the root of the small and large molars of the jaw, suppuration can go to the maxillary sinus and cause inflammation. In chronic fibrous periodontitis, there is a decrease in the number of cellular elements and an increase in coarse fibrous tissue. In some areas of the periodontium, inflammatory small focal infiltrates and vascular sclerosis are observed. The disordered arrangement of coarse fibrous structures in the periodontium gives it the character of scar tissue and accompanied by diffuse thickening of the apical portion of the periodontium. Chronic granulating periodontitis is characterized by the formation of granulation tissue, which contain a large number of capillaries, fibroblasts, round plasma cells, lymphocytes, and histiocytes. During the formation of young granulation tissue, the amount of glycogen, neutral and acidic mucopolysaccharides increases in it. Replacement of the apical portion of the periodontal tissue with granulation tissue is accompanied by destruction of periapical tissue with resorption of osteoclast not only in the compact plate and alveoli but also of cement and in some cases of dentine of the tooth root. Granulation grow into the bone marrow spaces of the jaw, forming fistulas with purulent discharge and sometimes subgingival or subcutaneous granuloma. Granulation tissue often forms on the wall of the fistulous tract and bulges out of it inform the soft growth. Chronic granulomatous periodontitis or granuloma is a more stable and less active form than granulating. Signs inflammatory edema and inflammatory hyperemia in the form of infiltration are replaced by proliferative processes. With granuloma as well as with chronic granulating periodontitis, there is a partial replacement of periodontal tissue with granulation tissue. However, in case of granuloma, the area of granulation tissue is determined from the surrounding bone by a peripheral fibrous capsule. The fibers directly pass into the periodontal tissue. Most granulomas, in addition to granulation tissue containing epithelial cords or epithelial lining, in this regard, root granulomas, according to their anatomical structures, are divided into simple or non-epithelial, and complex or epithelial. In a major granuloma, there are several zones that represent a single type of body defense against infection from the root channel. Well, first zone is a zone of necrosis. This area contains necrotic tissue and bacteria. Zone of contamination is the second one. This zone containing leukocytes, lymphocytes, and osteoclasts. Zone of irritation. The zone contains granulation tissue. There is no living microorganism in this zone. Zone of stimulation is a fourth zone. This zone is characterized by the very active or activation osteo and fibroblasts that create collagen fibers. A periapical cyst is a cavity formation with the epithelial lining of inflammatory genesis located in the periapical region of an unaviable tissue. The presence of an epithelial lining is a characteristic feature of the odontogenic cysts. The source of the epithelium is usually the iles of the malaise. These often the epithelial lining of the gingival bronchits, the epithelium of the paranasal sinuses, and the epithelial lining of the fistulas. When the cyst is located to the side of the tooth root, it is a lateral radical cyst. If a cavity formation is found in the apical region of the extracted tooth, it is a residual periapical cyst. Radiographically, most periapical cysts are represented by a rounded X-ray transparent area. The tooth associated with the cyst may be displaced and the tooth root is often resorbed. Radiographically, it is quite difficult to differentiate periapical cyst from the periapical granuloma. It is believed that a periapical lesion with a diameter of more than 2 cm is more characteristic for a periapical cyst. Pathogenesis of the periapical cyst. There are 3 phases of the pathogenesis of the periapical cyst. First of all, its inflammation response in the periapical region stimulates the proliferation cells in the islet of malaise. Of great importance in this situation belong to the epidermal growth factor, which accumulates in the periapical region and stimulates the proliferation of epithelial cells. It is believed that the formation of the cavity begins with heteropic degeneration and necrosis of epithelial cells located in the center of the islets of malaise due to malnutrition. Neutrophils enter the areas of necrosis. Multiple small cavities are formed, which emerge from one cavity filled with liquid. An increase in the concentration of various molecules in their formed cavity leads to an increase in osmic pressure need. According to the osmic gradient fluid from the surrounding tissues enter the cavity formation, contributing to an increase in the hydrostatic pressure in the cavity and accordingly its increase. Under the influence of high pressure and the activity of macrophages and lymphocytes, bone resorption can be activated, which can contribute to a progressive increase in cavity formation. This picture shows the morphological structure of a typical radical cyst. The epithelial lining formed by the prismatic villous epithelium is determined. In the environment of the epithelium, inflammatory infiltration is determined, which contains neutrophils. Electronic microscopy. Microvilli on the apical surface of epithelial cells are clearly defined on this photo. Periapical abscesses is an acute focal purulent inflammation in the apex of a non-viable tooth. The development of periapical abscesses can occur as a primary manifestation of periapical pathology, or it can form as an exacerbation of a chronic inflammatory process. A variant is possible when acute periapical inflammation does not lead to the formation of abscesses. It is correct to call this variant of pathology acute apical periodontitis. In most cases, the source of the infection is obvious, As a rule, it is pulpitis, however, cases of the development of periapical abscesses in the area of healthy tooth have been described. In addition to the above, periapical abscesses can occur as a result of trauma and therapeutic manipulation affecting the root channels. A periapical abscess is represented by a dense arrangement of a large number of segmental nucleated leukocytes with a mixture of macrophages and necrotic masses. Sometimes colonies of microorganisms may be present in the lesion focus. Complication of a periapical abscess is first of all sinusitis, most often it's maxillary sinusitis, osteitis, periosteitis, osteomyelitis, cellulite or phlegmon of the face and neck, Ludwig's angina, thrombosis of the cavernous sinus, and sepsis. Periodont. Periodont is a complex of tissue surrounding the tooth which ensure the fixation of the tooth in the jaw and its functioning. Gingivitis is inflammation limited to the soft tissue that surrounds the tooth. Conventionally, all types of gingivitis can be divided into such categories as gingivitis associated with the formation of microbial plaque, allergic gingivitis, gingivitis due to the exposure of infectious agents, or necrotizing ulcerative gingivitis, abscesses of the gums, gingivitis as a manifestation of dermatological, systemic, or other diseases, gingivitis of pregnant women. Inflammation in the gums can be located and generalized. The lesions may be limited to the age of the gums. We call it marginal gingivitis. Gingival papilla, it's papillary gingivitis. If there is a lesion of the age of the gums, papilla, and detachment gums, this form is called diffuse gingivitis. The incidence of gingivitis is quite high in all age groups. Women have a pronounced increase in the incidence of gingivitis during puberty and during pregnancy. Gingivitis in the initial stage is characterized by a mild infiltration by polymorphonuclear leukocytes, which are localized subepithelially. As the progression processes, the infiltration becomes more pronounced. Infiltrate along with the polymorphonuclear leukocytes, plasma cells, and lymphocytes are determined. Areas of fibrous, edema, and hyperemia may be present in varying degree of severity. Acute gingivitis is characterized by clear signs of gum inflammation. It's redness, moderate or severe swelling, and soreness of the gum. Against this background, bleeding or even ulceration of the gums may appear. In the inflammatory infiltrate along the plasma cells and lymphocytes, polymorphonuclear leukocytes are present. Chronic gingivitis is a slow symptoms disease characterized by mild inflammation of the gums. Local factors play the great role in the development of chronic gingivitis. It's dental plaque, dental stones, and so on. Microscopically, there is a big or moderate infiltration by plasma cells, lymphocytes, and macrophages. Necrotizing ulcerative gingivitis is an acute, non-contagious infection lesion of the gums, characterized by sudden onset, the formation of ulcers in the area of the gingival papillae, bleeding, and soreness in the lesion. Microscopic examination are non-specific. Surface effects are determined on the gingival papillae, the bottom of which is covered with fibrinose, purulent, and exudate. The underlying lamina propria is hyperemic, infiltrated with lymphocytes, plasma cells, and segmental nuclear leukocytes. Non-ulcerated epithelial loses the stratum corneum. Atypical gingivostomatitis or plasmatic gingivitis. Etiologically, the disease is usually allergic in nature. Numerous cases of the development of this variant of gingivitis have been described as a response to the use of chewing gum, herbal toothpastes, and others. In some cases, the etiology of the disease cannot be established. The onset of the disease is acute, characterized by soreness in the gum and hard palate. Increased pain is characteristic when using toothpaste, hot and spicy food. The defeat of the gums is diffuse, manifested by bright redness and loss of anatomical patterns. Lesions of the mucous membrane of the hard palate are usually less pronounced. Cases of involvement in the inflammatory process of the tongue and lips are described. A distinctive feature of the disease is plasmacytic infiltrate. Microscopic examination revealed a marked squamous hyperplasia with a focal ulceration and diffuse dense subepithelial plasmacytic infiltration consist with PCG. At high magnification, plasma cells were seen without a cellular atypia. The individual plasma cells had eccentric round cell nuclei with cartwheel chromatin pattern and abundant cytoplasm. Granulomatous gingivitis. It is characterized by development of granulomatous inflammation in the gum region. Granulomatous gingivitis can be a manifestation of specific infection granulomatous diseases such as tuberculosis, syphilis, or mycosis. Systemic granulomatous diseases like Crohn's disease, sarcoidosis, vaginal granulomatosis develop when foreign bodies enter the mucosa, in particular during dental manipulations. There is a variant of granulomatous gingivitis as an independent form which can be established only after excluding all the above diseases. Non-specific, we call it non-specific granulomatous gingivitis. Histopathologic picture. A characteristic microscopic manifestation of granulomatous gingivitis is a focal accumulation of macrophage cells in combination with lymphocytes. Often giant multinucleated cells are found in the focus of granulomatous inflammation. Particles of foreign material may be detected. In case of a specific infection lesions, microorganisms can be detected with the help of special stains or bacteriologically. Desquamative gingivitis. Lesion of the gums characterized by pronounced desquamation of the epithelium as a result of which some areas of gums acquire bright red or polished appearance. Desquamative gingivitis is often the initial manifestation of vesicular erosive lesions of the oral mucosa. The patients with desquamative gingivitis have disease such as lichen planus and various forms of pemphigoid skin lesions. A relation was found between the development of the desquamative present pathology in individuals with an increased level of estrogen. Some researchers have noted the relation of desquamative gingivitis with microbial plaque. Desquamative gingivitis usually being a manifestation of a particular disease cannot be considered as independent disease. The microscopic picture of desquamative gingivitis is determined by the disease of which it is a manifestation. It is medicinal gingival hyperplasia. It is an abnormal disease in gum tissue. Is a normal increase in gum tissue in response to the use of a particular drug. The name of hyperplasia does not reflect the essence of the process occurring in the presented pathology. Some the enlargement of the gums in the consequence of the proliferation of the component of the extracellular matrix and not the proliferation of the cells. Among the drugs that can cause gingival hyperplasia are anticonvulsants, calcium channel blockers, cyclosporines, erythromycin, oral contraceptives. There is a direct relation between the severity of gingival hyperplasia and poor oral hygiene. An ultrastructural study demonstrates the increase in gingival tissue volume is primarily due to connective tissue response rather than epithelial cellular involvement. The histopathology of the lesions All drug categories is similar and is characterized by excessive accumulation of extracellular matrix proteins such as collagen or amorphous ground substance. Varying degree of inflammatory infiltrate exists, while an increase in the number of fibroblasts remains controversial. The predominant type of inflammation of infiltrating inflammatory cells is plasma cells. Parakeratinized epithelium of variable thickness covers the connective tissue stroma, and epithelial ridges may penetrate deep into the connective tissue, creating irregular arranged collagen fibers. Next one is gingival fibromatosis. It's a slowly progressive enlargement of the gums of non-neoplastic nature due to the proliferation of the fibrous component of the connective tissue. Gingival fibromatosis can be familial or hereditary and idiopathic. The defeat of the gums is characterized by diffuse or local enlargement of the gums, the consistency of which is dense. The mucous membrane is weakly mobile. In most cases, gum enlargement begins before the age 20 and is often associated with teething of deciduous or permanent teeth. Sometimes the enlargement of the gums is pronounced to such an extent that they completely cover the crown of the tooth and prevent the lips from the closing. Fibromatosis from the gum can spread to the mucous membrane of the hard palate, the mucous membrane of the floor of the mouth. The gum in the affected area becomes dense and characteristic color. The surface can be smooth, granular. In some cases, papillary outgrowths can form. Histopathology. The affected gum is represented by dense connective tissue with low vascular and cellular components. The superficial epithelium can form areas of deep immersions in the underlying fibrous base. Signs of inflammation are either absent or mild. Periodontitis is inflammation of the gum tissue, which is associated with the loss of bone part of the periodontium and partial loss of the connective function of the periodontal ligament. The characteristic feature of periodontitis is the formation of periodontal pocket as a result of bone and periodontal distraction, as well as the margination of the cervical epithelium in the apical direction. The presence of microbial plaque is a key moment in the pathogenesis of periodontitis, and the concentration of microorganisms in blood is of great importance. According to modern concept, the pathogenesis of periodontitis is based on two key conditions: its polymicrobial synergy and dysbiosis. One of the key points in the pathogenesis of periodontitis is the formation of the dysbiosis, which contributes to the development of inflammatory reaction. Factors secreted by cells of the inflammatory series activates osteoclasts, which carry out the bone resorption. Matrix metalloproteinases activation, which stimulates the inflammatory response, is of great importance in the pathogenesis of periodontitis. Odontogenic cysts. A cyst is closed cavity formation. As a rule, have its own wall. The lumen of the formation may contain liquid, gas, semi-solid substances, and so on. Jaw cysts are classified as odontogenic and non-odontogenic. The odontogenic epithelium takes part in the formation of the odontogenic cysts. The jaw bones, with a few exceptions, are the only bones in which epithelial lean cysts occur. Non-odontogenic cysts of the jaw have no lining. Odontogenic cysts are classified in two groups: inflammatory and dysontogenic. Developmental odontogenic cysts that originates by separation of dental follicle from around the crown of unruptured tooth. Diagnosis required correlation with radiographic and or knowledge of radiographic finds. Second most common odontogenic cysts. Most common development it's most common developmental odontogenic cyst. Multiple simultaneous follicular cysts uncommon. Represents 20% of epithelium limb-joint cysts. Usually see in teenagers or young adults. Also can occur over a wide age range. If we'll talk about etiology, in normal tissue development, tooth enamel is produced by an enamel organ and ectodermally derived specialized epithelium. After enamel formation is complete, the enamel organ epithelium atrophies. This reduced enamel epithelium eventually merges with the overlying mucosal epithelium to form the initial gingival curvicular epithelium on the newly erected tissue. Follicular cysts form then when fluid accumulates between the reduced enamel epithelium and the crown of unruptured tooth. Radiology description. The most commonly well-defined unilocular radiolucency on X-ray often has sclerotic rim, can cause resorption of adjacent teeth. Microscopic features are defined by the presence of inflammation. In inflamed follicular cyst is fibrous connective tissue, hyperplastic non-keratinized epithelium, sometimes elongated interconnected rete bridges, chronic inflammation cells, cholesterol clefts, possibly formation of cholesterol granuloma, scattered mucous or ciliated or sebaceous cells uncommon but possible. Occasionally dystrophic calcification, odontogenic epithelial rays, small inactive repairing. In non-inflammatory follicular cysts, it's fibrous to fibromyxoid connective tissue. Linear epithelium is 2 to 4 layers of cuboidal epithelium devoid of superficial keratinization. Occasional mucous cells, rare ciliated cells, occasional dystrophic calcification, odontogenic epithelial rays, small inactive appearing. Odontogenic keratinocytes or keratinocytic odontogenic tumor, the keratinocytic odontogenic tumor or KCOT, formerly known as the odontogenic keratinocytes or KC, received its new designation in order to better convey in neoplastic nature. It is a developmental odontogenic tumor with many distinguishing clinical and histological features. Among them are potential for local destructive behavior, relatively high recurrence rate, and designation as a consistent finding in the unvoid basal cell carcinoma syndrome or Gorlin syndrome. OKC is a developmental cyst that arises from remnants of the dental lamina. There is an association with mutation or inactivation in PTCH1 gene, which activates the CHH signaling pathway and results in aberrant cell proliferation of the OKC epithelium. Histopathology. Typical histology shows an unflamed fibrous ball lined by folded, thin, regular parakeratinized epithelium, 5 to 8 cell layers thick without rete bridges. The perikeratin surface is typically corrugated. The basal layer is well defined and often palisaded with hyperchromatic nuclei, and focal areas shown reverse nuclear polarity. These features are diagnostic and distinguish OKC from other jaw cysts that can show keratinization. Methodic figures are often seen, but these are normal. Inflammatory lesions lose these typical features and are linked by non-specific stratified squamous epithelium with some degree of hyperplasia. OKC may show small satellite cysts or solid islands of in the wall, or may have budding of the basal layer. These features are more commonly seen in cyst association with nevoid basal cell carcinoma syndrome. If we'll talk about prognosis and prediction, treatment is the most often by enucleation or by surgical resection for large lesions. As typically we found an overall recurrence rate about of 25%. Lateral periodontal cysts and botuoid odontogenic cysts. By definition, it's lateral periodontal cyst, LPC, is a developmental odontogenic cyst linked by non-keratinized epithelium occurring on the lateral aspects or between the roots of erupted teeth. Botuoid odontogenic cyst, or BOC, is the multicystic variant of LPC. LPC and BOCs most frequently occur in the mandible with lower than 20% horizon in the maxilla. Almost all lesions have been reported to arise anterior to the malar, or in particular of the premolar region. LPCs and BOCs account for less than 1% of odontogenic cysts at all. LPC, BOC arise from odontogenic epithelial remnants, but the source is controversial. Origin from dental lamina, reduced enamel epithelium, or rates of malaise has been proposed. Histopathology LPCs has a characteristic histopathology that is similar to that of gingival cysts of the adult. It exhibits a high leaning of non-keratinized epithelium, typically consists of a single or double layer of the cells with focal plaque-like epithelial thicknesses. These often have a holed appearance, and the cells may have clear cytoplasm due to accumulation of glycogen. Separation of the epithelial lining from the connective tissue wall is common finding. The fibrous wall is uninflamed, but may show a gallonized band immediately beneath the cyst lining. The microscopic appearance of BOC is similar to that of LPC, except there are multiple cyst spaces. The microscopic appearance of BOC is similar to the LPCs, except there are multiple cyst spaces. Prognosis and prediction, as we can say that LPCs can be treated by enucleation without the removal of the adjacent tooth or teeth. Recurrence of simple unilocular cyst is rare, but recurrence is documented as many as 20% of BOCs, probably to the multicystic nature of the lesions. Gingival cysts. Gingival cyst is ontogenic cysts found in the alveolar mucosa. They can arise in adult and in infants. In adult, small gingival cysts, as many as 75%, occur in the mandible, in the premolar canine region. Gingival cysts of the infants present as smaller than 2 millimeters, white nodules on the alveolar mucosa and often multiple. Gingival cysts of the adult typically present as a painless, small, dome-shaped, elevated of the attached gingival, resemble a blister. If we'll talk about epidemiology, gingival cyst of the adult is rare, accounting less than 0.5% of all odontogenic cysts. The cyst, on histopathological examination, the cyst lies just below the normal oral epithelium and is typically uninflamed and linked by the epithelium composed of a single or double layer of cuboidal to squamous cells without rete bridges. Focal abrupt thickening is often present, producing plaques that protrude into the lumen or into the connective tissue wall. Clear cells is often present. Occasionally, the cyst lining is thicker and appears stratified squamous in character. The connective tissue wall may be contain islands of epithelium resembling epithelial plaques. Gingival cysts of the infant are rarely seen histopathologically, but most appear to be linked by the keratinizing epithelium. If talk about prognosis and prediction, we can say that in adults, simple excision is the treatment of the choice and typically curative. Recurrence has not been reported to gingival cysts of the infant undergo invasion or resolve spontaneously and do not need to be treated. Glandular odontogenic cysts. Glandular odontogenic cyst is a developmental cyst with epithelial features that simulate salivary gland or glandular differentiation. GOC occur exclusively on the jaw, with the mandible involves about 75% of cases. The most common presentation is painless swelling. Radiographs reveals well-defined unilocular or multilocular radiolucent lesion, which may have scalloped borders. GRC is typically associated with the roots of multiple teeth, and tooth displacement or root resorption is common. GRC is rare, accounting about less than 0.5% of all odontogenic cysts that occur over a wide patient age range, with increased peak in patients aged 40-70 years. There is no sex predilection. The etiology is unknown. GOC is thought to be a developmental cyst that arises from remnants of the dental lamina. Histopathology. Statistical analysis has shown that a confident diagnosis of GSC can be made when at least 7 of 10 specific criteria are presented. Some criteria are presented in all cases. First, it's variable thickness of the epithelium lining the cyst, from 2 to 3 cell layers of flattered squamous or cuboidal cells to thickened stratified squamous epithelium, and second one is luminal layer of cuboidal to low columnar cell, sometimes referred to as hobnail cell, present at least focally. All the criteria are present in most cases. Intraepithelial microcysts, apocrine metaplasia of the luminal cells, clear cells and the basal or parabasal layers, papillary projection or tufting into the lumen, and second one is mucous cells. The other 3 microscopic criteria for diagnosis are epithelial spheres similar to those seen in lateral periodontal cysts, which are frequently identified, cilia, which are occasionally seen, and multiple cysts, cystic compartment, which are sometimes present. Enucleation is the most common treatment for GOC, but is associated with high recurrence, about 30–50%. Calcifying odontogenic cysts. Calcifying odontogenic cysts is a simple cyst linked by ameloblastoma-like epithelium, which contains focal accumulation of host cells. COC can arise in either jaw, usually in the anterior region. Lesions associated with odontomas have a predilection for the anterior maxilla. The most common presentation is the painless swelling of the jaw. Radiographs reveal well-defined radiolucent lesions, which is usually unilocular and may have a scalloped border. Tooth displacement and root resorption are common. About half of all cases have a amount of calcified tissue or an associated odontoma. COC is rare, accounting for less than 1% of all odontogenic cysts. It occurs over a wide patient age range with Mean patient age of about 30 years. On the basis of its behavior and clinical pathological features, CRC is now thought to be developmental cyst that arise from the dental ligament. CRC is unicystic and is linked by epithelium of variable thicknesses. Some areas may be only a few cells thick or may show squamous changes there. However, the key diagnostic feature is the presence of well-defined basal cell layer of palisading columnar cells and thick overlying layer resembling the stellate reticulum of the enamel organ, with focal accumulation of host cells which may calcify. The region shows luminal projection to of the host cells or of enablostome-like epithelial proliferation. Small satellite cysts, islands, or epithelial host cells may be seen in the fibrous capsule. A variable amount of dentinoid is sometimes laid down adjacent to the epithelial lineage. In about 20% of cases, dental hard tissue resembling an odontoma are found. Enucleation is the treatment of the choice. Recurrence is rare and has been reported to occur in less than 5% of the cases. Autokeratinized odontogenic cyst, or OOC, is an odontogenic cyst that is entirely or predominantly lineated by autokeratinized stratified epithelium, squamous epithelium. OOCs are most frequently found in the mandible, accounting for 19% of cases, with about 75% of all lesions found in the posterior region. Multiple and bilateral cases have been reported. OOC usually present as a painless swelling, but many are found incidentally during radiographical examination for other reasons. Radiology shows a well-demarcated unilocular radiolucent lesion open with a corticated margin. Occasionally, cases are multilocular. Epidemiology. Due to changes in terminology, the true prevalence of OOC is uncertain, although it is known to be rare. In most series of keratinizing odontogenic cysts, OOC occur for about 10% of the cases. They occur over a wild patient's age range, with peak incidence in the third and fourth decade of life. Most studies show a male predominance. Histopathology. Histopathology shows an uninflamed fibrous wall linked by thin radial epithelium, 5 to 8 cell layers thick, but without red bridges. The surface exhibits autokeratinization with a prominent granular cell layer. Unlike in odontogenic keratocytes, cysts, the keratin surface is not corrugated is thick and lamellated. The basal cells are flat or cuboidal, but do not show palisading or hyperchromatic nuclei. Treatment is enucleation. Recurrence is rare and has been reported in less than 2% of cases. Thank you for your attention.